Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, brothers and friends, it's my great pleasure to start today's meeting. Today's meeting is very special in multiple ways. First of all, this is the first time we are meeting in a gather like this after the barricades of the Corona events. At the same time, we have also the pleasure of having a world figure in his field in the endocrinology and andrology, Professor Giovanni Corona. Third, it's also a special event to introduce something new to the Saudi market, a new BDF5 inhibitors. As all of you know, since 2015, which marks the introduction of tadalafil 5 milligram to the Saudi markets, we have no additional tools in our hands to treat our patients. So it might be a good also opportunity to discover the new introduction of Vanavil to the Saudi market. For this event, it's my pleasure to introduce our guest speaker today, Professor Giovanni Corona, a very well-known figure in the field of endocrinology and sexual medicine. Professor Corona is a qualified professor with Class 2 endocrinology in clinical and research activity in endocrinology and andrology. When I start reading his CV, my printer machine keep printing for more than 30 pages, and I'll just give you the most summarized outcome of this, of his excellent career. Professor Corona is an associate editor of the Journal of Sexual Medicine for quite some time. He also served as a board member of the Journal of Sexual Medicine and also a board member of Andrology Journal. He is a referee for several scientific newspapers, including most of the respected newspaper that we publish or read, including International Journal of Impotence and Research, Asian Journal of Andrology, International Journal of Andrology, Journal of Andrology, Andrology, Journal of Sexual Medicine, Journal of Sexual Medicine Review, European Urology, Journal of Urology, Nature Review of Urology, and the most prestigious Human Reproduction and Blues 1. And can you just tell you the top of his career to be a referee and a board member of some of those newspapers, of those scientific journals. Also, he's a co-author and a patent holder for structured interview on erectile dysfunction called CD, and it will be very interesting to know more about this tool in sexual medicine. Also, he's a co-author and patent holder for Andro test, which is another questionnaire or tool related to andrology field. He holds several international and local awards. He was nominated appointed as a member of the 3rd International Consultation on Sexual Medicine in 2009. He is also a member of the 4th International Consultation on the Sexual Medicine in 2015. He was quoted among the top 30 European researchers category in reproductive biomedicine. He is elected president of the Italian Society for Andrology and Sexual Medicine 2019 and 20. He is also elected chair of the Scientific Committee of the European Society for Sexual Medicine from 2017 and 19, and re-elected again to be also the chair up to 2022. And also it's my pleasure to announce that Professor Corona have been already elected as president-elect for the European Society for Sexual Medicine starting 2020-23. Professor Corona also was cited among the 20 best board authors. And also he was cited among the most important 1,000 scientists in the world by PLOS Biology. His publication, very extensive. He is an author for more than 288 publications in journals with peer review. His number of citations for the publication is more than 13,000 citations. In Scopus and in Google Scholar, more than 19,000 citations. He published books and book chapters and involved as a co-investigator in several national and international clinical trials. So it's with my name and the name of the Saudi Society of Men's Health, it's my pleasure to introduce Professor Corona. I'm looking forward for a very interesting talk. As you heard at the beginning, tonight talk will be divided among the past, present, and future of erectile dysfunction. Then we'll have a brief introduction about Avanaville by Arak Healthcare. Then we will end up by some questions. So please, I encourage everybody among the people present here to write down your questions. And also, I'm inviting also all our colleagues behind the scene. We have more than 200 people already online with the live streaming for this event. And I also encourage them to write their questions, queries in the Q&A question, and we'll be happy to address them with Professor Corona. So please, let's everybody welcome Prof. Corona.
So thank you for this kind presentation. It is a pleasure and honor to be here. My first time in your fantastic country. Fortunately, I have no time to visit it, but I hope to have this possibility in the near future. So first of all, before talking about Avanaville, our idea is to give you a better vision, so a better analysis on what erectile dysfunction is. So this is a review paper in which we summarize what indeed is the related risk factor of erectile dysfunction. So can you? Can you hear me? No. No, I prefer this one. Sorry. Can you hear me? Okay, that's fine. So in this paper, essentially we summarize what is the significance, the forthcoming significance of ED. Essentially here we we summarized all the meta-analysis regarding the relationship between erectile dysfunction and cardiovascular risk. As you can see, erectile dysfunction should be considered a risk factor for an overall cardiovascular risk, coronary heart disease, acute myocardial infarction, as well as stroke, up to twofold increase the risk. The same is for cardiovascular mortality and all-cause mortality. So essentially, erectile dysfunction is not just a symptom. It's a risk factor for forthcoming cardiovascular disease. And this is nowadays is well known. So ED is a risk factor for forthcoming cardiovascular diseases. Why? In this paper published some years ago in the Aging Male, we have written that ED subjects could be paradoxically lucky. Why? Because they have a unique chance not just to improve the erectile function, so to improve couple satisfaction, to gratify their partner, but indeed because they have possibility to rule out all the underlying factors. So to improve not just ED, but to improve overall life and cardiovascular risk. Accordingly, several traditional cardiovascular risk factors has been related to ED, including smoking, alcohol intake, physical inactivity, as well as arterial hypertension, diabetes mellitus, central obesity, dyslipidemia, and metabolic syndrome per se. How to manage the problem? I will analyze more deeply 4 different topics: dyslipidemia, arterial hypertension, hyperuricemia, and diabetes mellitus. What about dyslipidemia? This is a paper that we published some years ago in Journal of Sexual Medicine, including up to 4,000 subjects attending our unit. And essentially we found that the lower, as you can see, triglyceride levels, the higher triglyceride levels, the lower testosterone levels, the higher triglyceride levels, the lower calculated free testosterone, no modification of LH, meaning that probably there is a mixed hypogonadism, a combination of hypothalamus, pituitary factors, and testis factors underlying the problems, and the higher androtest score, meaning higher prevalence of hypogonadism-related symptoms and signs. And this was confirmed even after adjustment for confounding factors. So dyslipidemia, elevated triglyceride, for sure are associated with the reduced testosterone levels. But the higher triglycerides, so the higher quartiles of triglycerides, the lower, the worse erectile function, the lower IIF-5 score, higher CAD scale 1 score, meaning higher contribution of the organic factor underlying ED, the lower penile vascular flow evaluated in a flaccid condition, so before PG1 stimulation, and in dynamic condition after PG1 stimulation. And again, these factors were confirmed even after adjustment for confounders. So elevated triglycerides are associated with arteriogenic ED. We were able to follow up and to collect the incidence of major adverse cardiovascular events, including stroke, cardiovascular mortality, and morbidity in a subset of our patients, 1,000 and more than 1,600. And we found that the higher triglyceride levels, the higher risk of MACE, even after adjustment for confounders, as you can see, more than 2-fold increase the risk of MACE. So for sure, elevated triglyceride predicts not only erectile dysfunction, but also worse cardiovascular outcome. And this is a very important meta-analysis published in NASAN journal some years ago, including 93 trials and almost up to 26,000 men. The higher proportion of dyslipidemia, the lower outcomes in PDE5 inhibitors. How to manage the problem? This is a meta-analysis including the use of statins. As you can see, statins per se are able to increase international index of erectile function up to 3-point score. So dyslipidemia improvement can per se increase, ameliorate erectile dysfunction. Since statin can act obviously by reducing cardiovascular risk, by improving endothelial function, but also these are data coming from my mentor at Mario Maggi lab. As you can see, statins are able to block ROA-ROA kinase pathway, which is the main pathway involved in penile detumations. So statins essentially play in 2 different ways: long-term by reducing cardiovascular risk, acute phase by improving erectile function. Arterial hypertension. These are data again coming from our lab. We specifically evaluated pulse pressures, which is the difference between systolic and diastolic arterial pressures which is an index, one of the best predictor, one of the best index of arterial stiffness. The higher pulse pressure quartile, the higher prevalence of severe ED. The higher pulse pressure quartile, the lower penile vascular flow. Again, before PG1 and after PG1 stimulation in flaccid and dynamic condition. So elevated pulse pressure was associated with ED and again impaired vascular flow. Meta-analysis including more than 41,000 men, and among them more than 10,000 with ED. Arterial hypertension was associated with an increased age-adjusted increased risk of ED, up to twofold increased risk when all studies were considered, and the same when study using the best important outcomes. So the international function of the international index of erectile function was considered. Again, more than twofold increased risk. And again, this was also confirmed by adjusting for confounding factors, all studies and IIIEF studies. So arterial hypertension for sure is independently associated with ED. Again, data from our longitudinal analysis, the higher pulse pressures, so pulse pressures in the first quartile when compared to the higher quartiles, the higher risk of major adverse cardiovascular events. And this was confirmed. Look at this, pulse pressures, each 10 milligrams increment was the best, one of the best predictors when compared even to mean blood pressures, even after adjusting for several confounding factors. So pulse pressure again is associated with worse forthcoming cardiovascular risk. This was true not in older people, but very, very important in younger, so in those who were aged lower than 60. Because in older people, several associated morbidities can smooth the significance of ED as the predictor of forthcoming cardiovascular diseases. And again, this was confirmed after adjustment for confounding factors in a Cox regression analysis. So pulse pressures is for sure a risk factors for arteriogenic ED and for higher cardiovascular risk. And again, the higher proportion of hypertension, the lower PDA5 outcomes. How to manage the problem, and in particular, looking at the drugs involved in the treatment of arterial hypertension, one of the most conflicting issues is related to the use of beta blockers, as you know. So in order to try to better understand this issue, we are preparing a new meta-analysis by collecting all the data. And what we observed, essentially that in an unadjusted model, indeed, the use of beta blockers was associated with an increased risk of ED, up to twofold increased risk. It's true, beta blockers causes ED. But so beta blockers can increase the risk of ED. But looking at the meta-regression analysis, again, in unadjusted model, we found indeed that the older age, the higher risk. The lower smoking habit, the lower smoking prevalence, the lower risk. The higher prevalence of diabetes, the lower risk. The higher prevalence of cardiovascular disease, the lower risk. So the risk is essentially higher in less complicated subjects. Accordingly, in the fully adjusted model, the risk was not confirmed, meaning that probably the risk is related to the associated morbidities related to the use of beta blockers, not to beta blockers per se. Accordingly, in this very elegant study performed in Italy, the nocebo effect of beta blocker was emphasized. 3 groups of patients with hypertension. The first one was informed that this was just the use of atenolol, just a drug to reduce blood pressure. The second one was informed of the name of drug, beta blocker. And the third group was informed of the name of drug, beta blockers, and that this kind of drug could have caused erectile dysfunction. The prevalence of erectile dysfunction obviously was highest in the last group, and no effect, no difference in the efficacy of PDE5 inhibitors in all groups. Increased uric acid level. This is a very large longitudinal study performed in Taiwan, including, as you can see, more than 77,000 men. And as you can see, the presence of GOT at the beginning of the study was associated with an increased risk of ED during the follow-up. And these are the Kaplan-Meier curves showing this phenomenon. UK, similar results. The presence of GOT at the beginning, again, was associated with an increased risk of ED. And this is a meta-analysis summarizing all the available data up to more than 85,000 men. GOT was associated with increased risk of ED. So hyperuricemia is indeed associated with ED. The use of drug reducing uric acid for sure can reduce erectile dysfunction. Again, the treatment of the underlying disease can improve the outcomes. Finally, diabetes mellitus. Sorry. This is a, sorry. Back, okay, this way. Okay. This is a meta-analysis including more than 80,000 men, showing that diabetes mellitus was associated with 5-fold increased risk of ED. And these are data coming from our group in Italy, subject with recently diagnosed type 2 diabetes mellitus, showing that almost half of them reported erectile dysfunction. And the erectile dysfunction in subject with diabetes mellitus is due to a combination of psychological problems, so hypoactive sexual desire, depressive symptoms, as well as chronic problems, so organic problems, chronic complication, as well as the probably hypogonadism was another factor importantly associated to ED related to diabetes mellitus. And again, the higher proportion of type 2 diabetes, the higher proportion of diabetes, the lower PDE5 outcomes. How to manage the problem? Again, our group of patients followed for 2 years, and we found an overall improvement of ED in about 1 out of 3 of patients, so 30% of patients. And the improvement of glycometabolic control, glycated hemoglobin, dyslipidemia, uric acid was significantly associated with the improvement of ED and the improvement of ED-related depressive symptoms. What is the contribution of low testosterone, testosterone-related replacement therapy? This is again our data coming from our lab, showing that by comparing people from the general population, so seeking medical care for erectile dysfunction, or the general population, the spin-off of the European Mellitus study, we found that population of subjects seeking medical care for erectile dysfunction is a population enriched on hypogonadism, since it is enriched of metabolic disease, including central obesity and type 2 diabetes. Accordingly, there was an age associated with the risk of later onset hypogonadism in several metabolic conditions. Testosterone plays a crucial factor for regulating male sexual function. And testosterone can per se improve all aspects of sexual function, including erectile function, libido, intercourse satisfaction, overall satisfaction, and total IF-15 score. In particular, we found an improvement of 2.3 score in overall erectile function domain. But what does it mean, 2.3? By looking at the data coming again from PDA5, we found that 2.3 means that testosterone replacement therapy is clinically effective enough just in subjects with a milder form of ED. Accordingly, the effect was lower in more complicated subjects, such as those with diabetes. And weight loss, lifestyle modification is able to improve testosterone levels per se. And this is an update meta-analysis that we published 2 years ago. And the improvement of testosterone is directly related to the improvement of body mass index and to the improvement of body weight. And similar results for physical activity. So physical activity is able to improve up to nanomolar per liter level of testosterone. So the conclusion of my first talk is that ED must be considered the first sign of cardiovascular diseases. Metabolic diseases are associated with reduced testosterone levels, arteriogenic ED, and higher risk of major adverse cardiovascular events. The improvement of ED-associated disease can ameliorate ED itself and cardiovascular risk, as well as PDA5 inhibitors outcomes. Each patient seeking medical care for ED must be accurately evaluated and treated, first of all, for the underlying metabolic diseases. Now is important to look at how PDA5 inhibitors works in this kind of patients. Considering the available guidelines, I'm proud to say that I'm also one of the members of the European Association of Urology Guidelines. There is no questions. Recently, the summary of the guidelines has been recently published in European Urology. There is no way, no questions that PDA5 inhibitors, due to the efficacy and due to the low incidence of side effects, should be considered the first medical line therapy for ED. But the dropout with the use of PDA5 inhibitor is still quite high. These are data published in 2006, just with the use of sildenafil. Dropout 43%. Data 6 years later, 2012, sildenafil, vardenafil, and tadalafil, so the first generation of PDA5 inhibitors. Again, the dropout quite high, around 50%. So despite their efficacy, the PDA5 dropout is still very high regarding the first generation of PDA5. But what is the real impact and how can we manage? How can we improve the outcomes and how can we reduce the dropout? In order to better understand the real impact of the dropout of the first generation of PDA5 inhibitors, we performed this meta-analysis published in the Andrology some years ago, and eventually we collected 22 observational trials, including sildenafil, vardenafil, and tadalafil. And essentially we found the monthly dropout was around 4%. So meaning that 4% of the patients who were prescribed PDE5 inhibitors abandon this therapy each month, meaning that in 1 year, about 50% of people who were prescribed PDE5 inhibitors abandon this therapy. And what are the main determinants of this phenomenon? Again, by performing a meta-regression analysis, we found that the dropout was higher in younger people, probably due to psychogenic problems. So after a short period of therapy, people were able to restore erectile function. The dropout was higher in those studies with a shorter follow-up, again, probably due to more psychogenic ED subject. The dropout was indeed also higher in subjects with more complicated problems, higher prevalence of hypertension, higher prevalence of diabetes mellitus. So the dropout was inversely related to study follow-up, and it was higher in younger subjects and in those with a higher prevalence of associated morbidities. Essentially, we identified 6 main reasons leading to a dropout. And each factor plays, look at the overlap of the bars, each factor plays an independent role. So partner-related problems, comorbidities, as I told you, cost, lack of efficacy, ED recovery, and side effects. So 6 main identifying reasons, and each factor plays an independent role. How can we manage the situation? How can we improve this situation? Essentially with 2 main actions: better information and specific tailored therapy. Is better information after more than 20 years of the launch of sildenafil still required or not? My answer is yes, and I will demonstrate you. These are data produced in Italy. Telephone survey with sildenafil. We were in 2004. More than 16,000 calls. Look at this. People who declaring erectile dysfunction lasting more than 3 years, around more than 40%, 41% did not declare to have a contact with their physician, probably due to fear, embarrassing, and so on. 2004. 2014, 10 years later, Europe, France, Germany, Italy, Spain, and UK, up to 30,000 men, web survey, 68% did not use medication. In the younger group, 1839, only 48% declared to have a close relationship with their physician. So a large number of ED patients do not have a close relationship with their physician. 2018, paper published by our group, almost 1,000 men, again web survey, who declared the use of PDE5 inhibitors in the previous 3 months. Almost 50% of them did not obtain a medical diagnosis of ED, self-reported erectile dysfunction. 11% declared the use of PDE5 inhibitors, but not to have erectile dysfunction, and only 40% of them reported a medical diagnosis of ED. And this is very important. Consider what I told you, considering the underlying factors, the cardiovascular risk related to ED. Accordingly, we found that those who received a medical diagnosis, a formal medical diagnosis, were older and reported a higher risk of associated morbidities, particularly diabetes. And people who declared to have a medical diagnosis of ED used the drugs to improve erection, to gratify the partners, and the drug was prescribed by the physician and bought in the local pharmacy. And again, this is very important. So more often prescribed a higher dosage of PDE5 inhibitors, able to use official traditional pharmacy than the rest of the sample. So performance, essentially, who does not receive the formal diagnosis were younger, healthier, not receive the formal diagnosis, not considering themselves as affected by ED in 11%, use PDE5 inhibitors just for curiosity and buy PDE5 online. This is very, very dangerous. So better information, even at this day, is still required. Specific tailored therapy. Comorbidity and lack of efficacy were two of the most important main factors leading to PDE5 discontinuation. Data in a very difficult population, diabetic population, coming from the first generation of PDE5, tadalafil, vardenafil, and sildenafil, SEP3, successful intercourse, less than 50% of success rate. Data on avanafil, published in 2012. These are people, almost 400 people, who declare failure rate in maintaining erection in more than 50% of cases and with pathological erectile function domain. 4 weeks of washout period and 12 weeks of active treatment, 130 on placebo, 129 on avanafil 100 milligram, and 131 in avanafil 200 milligrams. Look at this, almost 50% of them declared severe problems. So this is a very complicated population. Look at this, SEP2, so erection sufficient for penetration at the end of the treatment, up to 63% declared a successful SEP2, and up to 6 hours after the administration, almost 70% of people reported a successful intercourse, so SEP3. This is a very, very interesting new study performed from Egyptian group, 400 adult patients treated with erectile dysfunction and impaired endothelial function, treated with daily, 50 milligram daily of avanafil for 4 weeks, placebo-controlled. And again, look at this, 37% with diabetes mellitus, 22% with hypertension, 11% with dyslipidemia, and 28% with a combination of diabetes mellitus, hypertension, and dyslipidemia. Again, a complicated population. Improvement of several markers of endothelial function, but look at the last line. Look at the improvement, the percentage change of International Index of Erectile Function, doubled in the avanafil group when compared to placebo. So avanafil shows high efficacy in complicated patients, diabetes, hypertension, dyslipidemia, and probably daily administration can result in more effective outcomes. We have at least one paper showing this. Radical prostatectomy, another very, very complicated population. Similar criteria, more than 50% failure rate, erectile dysfunction pathological, 4 weeks washout, 12 weeks active treatment, 100 on placebo, 99 on avanafil 100 milligram, and 99 on avanafil 200 milligrams. Severe problem obviously here in almost 70% of the cases, the vast majority of the cases was robotic surgery. SEP2, end of the treatment, 41% with avanafil 200 milligram, but very, very interesting. SEP3 within the first 15 minutes, around again 40% with avanafil 200 milligrams. This is a meta-analysis published by our group some years ago, looking at the erectile function recovery in patients treated with PDE5 inhibitors after bilateral nerve-sparing radical prostatectomy. And look at this, avanafil resulted with the highest odds to the improvement of erectile function after radical prostatectomy. So avanafil shows again high efficacy in patients treated for radical prostatectomy. So what are the overall data coming from avanafil, the new generation of PDE5 inhibitors? Essentially, we collected all the data in this meta-analysis published some years ago. And by SEP3, we found when compared to placebo, avanafil resulted to be improved to have a successful intercourse up to 4-fold increase the risk. Very, very interesting. The SEP3 show a successful intercourse within 15 minutes up to 12-fold possibility when compared to placebo. SEP2, erection sufficient for penetration, up to 2-fold increased possibility when compared to placebo, and normalization of erectile function domain up to 2-fold increased possibility when compared to placebo. Why it is important? A tailored therapy, because some associated morbidities can result in worse outcomes because we did not pay attention. Avanafil dose adjustment is not required for men with mild to moderate renal or hepatic impairment. And these are the curves that plasma concentration profile showing this phenomenon. But look at this. I don't know how many of you is aware that tadalafil dosage is increased, tadalafil level are increased in subject with even milder renal impairment. So tadalafil should not be considered the first option in subject with renal impairment. And the same is for sildenafil and vardenafil with just milder hepatic impairment. Conversely, no dosage required for avanafil, at least in those with mild moderate problems. So avanafil shows similar efficacy when compared to first-line PDE5 inhibitors in the general population and does not require dose adjustment in subject with mild moderate hepatic and renal impairment. Drug interaction. As you know, nitrates as the only specific contraindication for all PDE5 inhibitors. A period up to 24 hours is considered for sildenafil and vardenafil. Probably 12 hours are enough for avanafil, and up to 48 hours for long-acting tadalafil, recommended against taking nitrates. Alpha blocker, there is just a precaution for all PDE5 inhibitors with the possible interaction known for all other kind of drugs involved in arterial hypertension. Very, very interesting. There is a precaution for vardenafil with the use of some antiarrhythmics, such as one of them are quite used, amiodarone and sotalol, due to QT interval prolongation and high risk of torsade points. The precaution with avanafil with the use of verapamil, and precaution also for all other kind of PDE5 inhibitors. SRI can interact with PDE5 metabolism, so are inhibitors of hepatic enzymes, so there is an increased risk of systemic exposure of the dosage, so the dosage should be reduced. No specific study with the use of fluoxetine, and possible additive hypotensive effect with the use of IML. Phenobarbital, phenytoin, and carbamazepine, again, are CYP inducers, so potentially reduction in this case of the systemic exposure, so we need to prescribe the drug at the highest dosage since the beginning. Some minor interaction with some antibiotics, so some macrolide antibiotics are inhibitors of the hepatic enzyme, so increased systemic exposure, reduction of the dosage. So conversely, rifampicin is an inducer, so precaution, and again, reduction of systemic exposure. In this case, we need to increase the dosage. Finally, some antifungals are inhibitors. Again, we need to reduce the dosage, as well as with some antiretroviral protease inhibitors. Finally, another important issue is the use of anti-acid that cannot be reported by the patient and can cause especially tadalafil absorption reduction, resulting in negative outcomes. So nitrates remain the only absolutely contraindication of PDE5 inhibitors, possible interaction with alpha blocker and some antiarrhythmics and chemotherapies. Side effects, another crucial point. This is a meta-analysis published in European Urology in 2015 and 15 showing that avanafil is the new generation of PDE5 inhibitors showing the lowest side effects when compared to the first generation of PDE5 inhibitors. So avanafil is associated with the lowest incidence of side effect despite similar efficacy when compared to the first generation of PDE5 inhibitors. And this is the summary of the data coming from our meta-analysis. Any adverse event when compared to placebo, obviously there was an increased risk. And these are the specific plot showing the risk of avanafil 100 milligram and avanafil 200 milligram. But these side effects were not significantly associated with drug discontinuation during the placebo-controlled study. This was not significant. And again, this is the specific plot of avanafil 100 milligram and avanafil 200 milligram. Flushing and ADH were increased. The risk of flushing and ADH were increased with the use of avanafil. And these are again the plot regarding 100 milligram, 200 milligram for flushing, and ADH 100 milligram and 200 milligram. But no significant risk, increased risk of nasal congestion and back pain. And again, these are the specific plot for nasal congestion and back pain. Why? Because avanafil shows the highest selectivity for other PDE5 enzyme. Look at PDE6, which is the one involved in the vision. Look at PDE11, which is one probably involved in back pain. As you can see, tadalafil, which is the drug more frequently associated with back pain, shows the lowest selectivity. And PDE5 inhibitors and PDE1 is the one involved in vasomotor problems. Accordingly, this is a 52 open label study in which 700 people, more than 700 people were prescribed avanafil 100 milligram, and they were allowed to increase the dosage or to, if not effective, or to reduce the dosage due to side effect. And look at this, only 0.4% requested that their avanafil dosage be decreased due to adverse event. And the previous paper looking at the use of daily avanafil, just 3 patients in the avanafil group, similar to the placebo group, abandoned the therapy. So avanafil 200 milligram was not associated with significant incidence of back pain and nasal congestion when compared to placebo, and probably this can reduce the dropout. Finally, another crucial point, partner-related problem. As you can see, avanafil 100 milligram and avanafil 200 milligram showed a significant efficacy when compared to placebo just after 10 minutes of the administration. Now, this can guarantee a better spontaneity of the intercourse and probably again ameliorate the couple fitness. And this is the data coming from our meta-analysis of sexual intercourse within 15 minutes regarding SEP3, up to 11% for increased risk, increased probability when compared to placebo. Why? Again, because avanafil has the shortest median time to reach maximal plasma concentration, and as I told you, can last very long. I showed you some data in diabetic population. So my final conclusion, 50% of men abandon first-line PDE5 inhibitors. So the dropout of first-line PDE5 inhibitors is quite high. The rate might be improved by probably modifying lifestyle behaviors, improving comorbid conditions, diabetes, dyslipidemia, and so on, treating hypogonadal patient with testosterone, educating patient on the correct use of the drugs, optimizing the dosage. Probably the highest dosage should be suggested since the beginning. Avanafil shows high efficacy even in more complicated patients with limited side effect and dropout, tailoring the proper drug to the proper patient. Thank you for your attention.